Okay, so a little bit about the background of Candida auris. So, Candida auris was first identified in 2009 in an ear canal of a patient in Japan. Um, Candida auris is one of the World Health Organization's critical part of their critical fungal group. So the top four are Aspergillus, Candida auris, Candida albicans, and Cryptococcus. So, those are organisms that we're concerned about preventing transmission. Around the same time that this case was identified, they began to see the emergence of four genetically different clades of Candida auris. And there were four clades initially identified, clades 1 through 4, in different areas of the globe. And it's thought that there is an impact on environmental warming as to why this is happening. And also, emerging resistance is also thought to be related to the azole use in agriculture. So, spraying antifungals on our crops and that kind of thing. So we're not really clear why, but we do know that it's spreading quite rapidly. So 5 years after that first case was identified in Japan, the first US case was identified in a patient on the East Coast. And then in 2018, a fifth clade was identified in Iran. So a little bit about Candida auris. I like this image because it shows budding yeast and how they reproduce the daughter cells as those circles on the end it basically break away from the mother, and it's an interesting picture to me. And the other thing that is important about Candida auris for us as healthcare providers is that it's a sticky organism. And I'm going to talk a little bit more about that later, but it produces a protein called an adhesin that allows it to adhere very efficiently to surfaces, our fomites in our environment, as well as our skin. So we'll be talking more about that. So Candida auris it can be sensitive, but it's often resistant to multiple drugs, particularly the azoles and amphotericin Bs. The icosapent, I have trouble pronouncing that, even though I've practiced, is the drug of choice for treatment of Candida auris, resistant Candida auris, but there have been pan-resistant isolates identified. Candida auris readily colonizes the environment as well as susceptible patients and is spread through contact. It can persist in the environment, in the healthcare environment for, right now they're saying 4 weeks. And it's also resistant to many germicides that we use. So a real difficult collection of things for this pathogen when we're trying to deal with it in the clinical setting. So then what are the risk factors for a Candida auris for our patients? So those are the individuals who are going to have serious underlying medical conditions, who have long healthcare facility stays, that are exposed to lines and tubes as part of their medical care, have frequent healthcare worker contact, have a lot of exposure to antibiotics. And also, if they're receiving healthcare in a facility or a geographic area where there is lots of Candida auris, they're going to be at higher risk for acquiring this organism. Mortality ranges with this, with invasive candidiasis, anywhere from about a third to a little over 50%. So it's quite a serious infection when it develops from occurs with invasive disease. So diagnosis, patients can be colonized with Candida auris and not be aware of it. The symptoms of a Candida auris infection are very nonspecific. The infection may be resistant to commonly used antifungals, so that can sometimes trigger concern about, hey, what's going on with this infection? It's not responding to fluconazole or whatever we're giving. So that can sometimes raise levels of concern. Another factor in it is that the speciation of Candida species, Candida auris, is sometimes difficult and can be misidentified. So it really is dependent on the instrument that's used in the laboratory. So our work as infection preventionists with our laboratory to understand how are they identifying these Candida species fungal isolates to be sure that they're capturing those infections or those isolates when they occur. MALDI-TOF is the equipment, my understanding, that is most effective now in identifying Candida auris. So part of that misidentification, it's helpful for you as an infection preventionist to know what is the identification method that your laboratory is using. And if it's MALDI-TOF, you're probably in pretty good shape as far as identification. But if you're using one of these other systems, it's important that you really talk to your lab and understand what their processes are for identifying clearly if they're identifying Candida hemuloni, if they're have some additional measures to confirm that. If you do have a new case that's identified as perhaps previously known and are admitted to your facility, it's important to report those cases. So here's the number for that ACDP on-call team phone number. And then I guess most importantly, if your lab has questions about identification, please direct them to the OHA, HAI team for additional information. So in summary, these Candida auris causes serious fungal infections in the healthcare settings. They're they are often multi-drug resistant, and some strains are pan-resistant. They have an attributable mortality rate of about 33%. They are colonized, they have this proclivity to colonize patients and the environment. They create serious potential for outbreaks in hospitals and nursing homes and can be difficult to identify with standard lab testing methods. So I want to show a little bit, I'm going to go through it real quick, but just as far as how Candida auris has spread across the United States since 2013, 2016. So here you can see the first clinical cases were identified in 2016, and they did a look back, and they were actually able to identify additional cases back to 2013. So we had just a few cases on the East Coast, mainly North New England, and also some cases in Chicago. And then just 1 year later, we have seen a jump now from just a few states to now 4 states now to 10. And you can see the concentration of cases are increasing in New York as well as in Illinois. And now we're going to jump again ahead to 2021. And a year after that, now we have about half of the states having at least one clinical case. And in 2021, Oregon had its first case, which resulted in a 3-individual outbreak, which I will mention was very successfully managed by the facility where those cases were identified. And you can see that those high populous states, Texas, Florida, New York, California, are seeing much more transmission and more of those cases. So now here we are at 2022, and this was the last map that I was able to get from the CDC website. And doesn't include a very big outbreak that happened in Mississippi that started with 3 clinical cases in December at the end of 23, and now is a very large outbreak of over 50 cases involving about 7 facilities. So a pretty significant spread there in Mississippi. And then also, Oregon had our 4th case of C. auris in 2023 from an out-of-state patient who presented for care in Oregon while they were traveling. So that was some additional Candida auris that we saw here in Oregon. The other thing that it's important to recognize in looking at this map is that there are some states that have done very well and managed to maintain low prevalence. In particular, Oklahoma, North Carolina, and Connecticut, you can see we're able to really get that, and Oregon as well, to really get that under control and prevent ongoing transmission. In California, this can be a little deceptive because the entire state is red, but the majority of cases occurring in California are really in Southern California up to Central California. And there's almost a line that you can see where cases sort of stop there in Central California. So we are anticipating a northern march, so to speak. But right now it's concentrated more in our neighbors' southern and central part of the state. So it's important to know that there's a lot going on behind the scenes for this Candida auris prevention effort. Oregon Health Authority has expanded the HAI team, where we now have an additional epidemiologist who's dedicated just to multi-drug resistant organism surveillance and response. And in addition, this year we have 2 new dedicated infection preventionists. I'm one of them on the west side of the state, and there's another on the eastern side of the state, Elizabeth Johnson, who's dedicated really to help prepare facilities for Candida auris and respond as well. There's also the antibiotic resistance exchange, information exchange, or ARI, which provides alerts for emergency departments and skilled nursing when a patient is admitted with an MDRO. This was launched in October of 2022. I have to say, I still don't know a lot about it, but if you're interested in that program and not currently participating, send me an email and I will link you up with someone who's more knowledgeable about it than I am. We also work very hard with our public health partners to support them by providing targeted training on CPO and Candida auris prevention and response. We have a lot of our public health partners here on the call and participate in IP Power, which I love and think is so important and valuable. And also, we have our ARLIN partnership. So ARLIN is the Antimicrobial Resistance Lab Network that is a series of laboratories across the United States that are responsible for helping us detect, respond to, and contain emerging threats like C. auris. And then at the bottom of the slide here, near and dear to my heart, is working closely with facilities who are most at risk of encountering a C. auris case and who are at risk for an outbreak. So that's my passion, and those of you who work with me know that I really enjoy that aspect of the job. So I want to talk a little bit about our infection prevention consults, and these are really important to our program from a perspective that, number one, they're non-regulatory. I know sometimes when somebody hears that the state's coming in, there's a little freak out factor, and we're non-regulatory in this role. We're free of charge. Our goal is to be educational and collaborative. I'd like to think of the ICAR process as a contrast between fire prevention and firefighting. I much prefer proactive work because it's always much more difficult to respond when the barn is already burning down and people are, at wit's end. But we do have both aspects. So there's that responsive ICAR or infection control consult and the proactive. And what we focus in on, and this is a bit of a pitch because I would love to hear from you and be invited to participate with you in a proactive consult, but it's really about getting prepared, assessing your risk, identifying your infection control gaps, sharing tools and resources that other facilities have used or other organizations have created or that we have that can help you prepare, and then also providing education. So that's the infection prevention consults. I'm done with that pitch. All right, so I want to talk a little bit about colonization and infection with Candida auris. So it's, patients can be colonized with Candida auris. It can live in them or on them without causing symptoms, not having an infection. And this colonization can persist for long periods of time and can spread even though there's no active infection. Also, individuals who are previously identified as being colonized with this organism are at greater risk for developing an infection. So knowing that someone has a history of colonization is really important in managing their clinical care. And then we have clinical cases where Candida auris actually finds entry into the body, causing an infection often with symptoms. They can still spread the disease here as well. And as we mentioned before, they have poorer outcomes with a higher mortality rate. So keep in mind that difference between colonization and infection, and there are still infection concerns about both. So now I want to talk a little bit about getting prepared. And again, that's part of the prevention, fire prevention rather than firefighting. Last Thursday, Salem Health did a wonderful presentation at our regional APIC. So I had some learning from them as a first experience. But universally, I think some of the things that are considered are really pull your work group together, your stakeholders, infectious disease, infection control, housekeeping, bed control, and nursing in order to really make sure you have policies, procedures, standard work, whatever you call that, in place that you can quickly activate should you have that first case, when you have that first case identified. It's also important to have an initial response plan, know what you need to do and who you need to mobilize in order to manage. Communication is key. You want to make sure that you're communicating to efficiently, effectively to the right people in order to raise awareness and understanding. One of the lessons that Salem Health shared was be flag ready. Have that Candida auris flag in your toolbox, in your information system, in order to be able to turn it on when it's needed. And not wait for your first case to be scurrying around trying to get that flag created. Educating frontline staff ahead of time will be incredibly helpful, not only from a maintaining calm and preventing panic perspective, but also for additional eyes paying attention to what's going on in the environment and with that care of that patient. Have your handouts ready. So know what you want to educate and communicate to your staff when that case occurs so that you can readily just print those off and get them out to your units. And then also, it's important that you, number one, perform a risk assessment for your own facility with Candida auris based on your own population. What are the feeder facilities that you're bringing patients in most commonly for care? If you're admitting folks from out of state or from, skilled nursing or LTACs in Southern California, you're going to have a higher risk of initial C. auris cases. So another piece of that toolbox is to implement Candida auris screening as a standing order. So we'll talk a little bit more about that as well. I wanted to mention here that part of what you want to be thinking about is when you do your annual risk assessment, and I know hospitals do this routinely, a lot of our long-term care facilities are now starting to do these, but what you want to be doing is really thinking about your risk assessment on a unit level, from hand hygiene compliance and PPE compliance, your cleaning effectiveness, how well are we doing with those process monitors that we follow, but also what's happening with our outcomes monitoring. If we have a unit where we're seeing a lot of CLABSIs, a lot of CAUTI, a lot of hospital-acquired MDROs, that can be a signal that there's infection prevention practices that are challenging on that unit, and focus on those prior to your first case to try to raise up those practices, and also be aware of them as vulnerability with that first case so that you can tailor your activities in response to that unique healthcare setting or unit. So I'm going to borrow from Lemony Snicket here a little bit and talk about systems failures and healthcare associated infection as a series of unfortunate events. So Candida auris needs fewer holes in the Swiss cheese for transmission. So, when we see any one of these components of our system failing, we're more likely to have an adverse outcome. So, shedding of shedding of organisms in the environment by a colonized or infected patient then provides for contamination of the environment. And then if we have cleaning and disinfection failures, then we're more likely to have staff hand contamination, equipment contamination. And then if we have non-compliance with hand hygiene, then we have transfer to the next patient. So really thinking about those systems failures and those elements of your risk assessment that impact these failures is really important in shortening the transmission period. So, when we look at who are our feeder facilities, what are the risks that a patient brings in with them, Oregon Health Authority currently recommends that Oregon hospitals, long-term acute care hospitals or LTACs, and our ventilator-capable skilled nursing facilities test patients, selected patients for Candida auris and CPO colonization at the time of admission. So the criteria for that, and I'm going to just give you one strategy, but do want to mention that there are two additional strategies that I'm not going to dive into that are available in the strategy guide that I'm going to attach to the follow-up email. But if you have a patient who's had the following in the past 12 months, we would suggest screening. So if they've spent a night in a healthcare facility, hospital, long-term care outside of Oregon, including anywhere outside of the United States, or had outpatient surgery outside of the US and Canada, or have had hemodialysis outside of the United States and Canada, then you should consider implementing admission screening if you already haven't. And as I mentioned, there are two other screening options. Um, when you implement screening and you have a flag triggered for rule out C. auris, place those patients or residents on empiric contact precautions until you know what their screening results are. That can prevent a lot of headache down the road as far as going in and doing additional screening of patients who might have been exposed. So responding to a case. So it's important. I always like to say emotion is really infectious, isn't it? So it's really important that those of us who are responding and guiding others through these events are able to maintain calm and communicate calm. So the first thing is to reassure people that these patients can be managed with appropriate precautions. When we communicate, we want to maintain calm to the frontline staff. We don't want to freak them out. We don't want to scare them. We can have a lot of influence out of how people are reacting to this. You want to plan to increase your rounding in your audits and also manage expectations. Tell people ahead of time that when we have the first case, know that we're going to be doing a point prevalence survey, that people are going to be on isolation, that there's going to be increased attention to the unit and the areas that are impacted, so that they understand that that's part of the routine with any one new case of this. And then also, emphasizing those basic infection prevention practices around hand hygiene, the use of germicides, and an effective cleaning and disinfecting, specifically with List P germicides. Communication, again, is so important. A single case of Candida auris should trigger notification to your primary healthcare provider, to your infection preventionist, to the frontline unit staff caring for the patient. Oregon Health Authority also needs to be notified as part of, our reportable diseases, and your local public health representative, and also your key partner, your housekeeping supervisor, should be included in your initial communication plan. You want to ensure that that continuous chart flag is placed and maintained to communicate that this patient has Candida auris and that additional precautions are indicated. And then ideally, if you can, and this is just planting a seed, but to have that flag generated at a lab level where it takes it away from an individual to ensure that flag gets put in place can be really useful. So if it can be placed on the chart at the time of identification, it's very helpful. If possible, include that enhanced cleaning, private room, and barrier precautions are required as part of that flag. And then also, if possible, and I know sometimes it's not, try to avoid manual flag placement. It's too error prone. You want to maintain those Canada flag in isolation flags indefinitely. And then when you do inter-facility transfer, or even intra-facility transfer, you should include both written and verbal handoff communication, because you don't want this to get missed. The consequences of missing a report for Candida auris is huge for the receiving facility. So have some redundancy in your communication plans. Some patient care considerations. These individuals should be in a private room and a private bath. They should have equipment that is dedicated to them wherever possible. Minimize room supply. Know that the recommendation, if you have items, whether they're in drawers or cabinets that are left behind when that room is emptied, when the patient is discharged, the recommendation really would be throw everything away because of the risk of contamination. And if you're throwing a whole lot of stuff away because you bring in excess supplies, it's very wasteful. So something to really think about. And then patient education is really critical here because a well-educated patient can really serve as a first reporter for Candida auris colonization to all of their future healthcare providers. So when we do a good job educating the patient and family and visitors, it can pay off for quite a long time. For our public health folks who are on the call, make sure that you get those wallet cards out there to support patients in communicating with their providers in the future will be very helpful. And then for everyone, emphasizing the importance of hand hygiene. Additional patient care considerations, you might want to consider halting admissions to the affected unit if that's possible. Salem Health reported using disposable dietary trays. I'm not sure if that's actually included in CDC recommendations. I haven't verified that, but I thought I would just mention that as an option. All charts for patients who have a travel or a flat, what do they call it, who are identified as being at risk should have their chart flagged as a rule out Candida auris until their screening cultures are available. Those results are complete. When looking at collecting these swabs for patients, there are some hospitals that do a patient assent versus a formal consent. Assent processes tend to work much more effectively and are a little bit less alarming, quite frankly, for the patient when agreeing to be swabbed. So something to think about to try to get your facility doing assents versus consents. I'm going to talk a little bit more about CHG bathing on one of the next slides. And then it's also important to make sure we have a protocol for in-house patient transport. Things such as the patient will have a CHG bath, will be changed into a clean hospital gown, clean linens prior to transfer within the building. And then also be aware that there may be discharge barriers that you bump up against. And if you have facilities that are commonly part of your discharge network, I can help, Elizabeth and I can help in educating for discharge. So we are aware that that has been a reported barrier for facilities in other states who've had a lot of Candida auris patients. Strongly encourage increased monitoring of all your processes. So hand hygiene compliance, PPE donning and doffing, sharing, shared equipment cleaning and disinfection, and effectiveness of room cleaning. If you have the technology available, if you can do ATP testing after shared equipment is before shared equipment is reassigned, that's ideal. If you can also do ATP testing for effectiveness of room cleaning, it's very valuable. I've had some facilities report that they actually have the infection preventionist who would clear a room for reassigning based on ATP testing. So lots of things to consider how you want to approach it within your organization. And then also really have increased IP visibility on your unit and the unit or units that are impacted. Just seeing an IP sometimes can trigger people to clean something, perform hand hygiene, even if they don't need to. So, be visible out there on your unit. I'm going to talk for a few slides here about enhanced cleaning and disinfection. As I mentioned, Candida auris is a sticky organism that produces a protein called adhesin. So it's effective at colonizing and contaminating the environment. I am now recommending universally that when you choose your germicides, be using List P germicides, not only for your wipes that you're cleaning contaminated equipment, but also for your general disinfectant that your housekeeping is using. And I asked Salem Health at their presentation last week if they were using a List P germicide when they had their first patient. They didn't know it was a List P germicide, but they were using it, and they stated that they thought that was part of the reason why they didn't have ongoing transmission. You want to make sure that folks are really adhering to those contact and or dwell or wet times. And then also, because it's a sticky pathogen, wiping something off, using a little elbow grease, as we say, when cleaning is really important. If you have, foggers for facilities and long-term care facilities that have those foggers, they're not a replacement for cleaning, manual cleaning of surfaces. Also, you might want to consider using adjunct environmental disinfection measures such as UV lights, and implementing, as I mentioned, post-cleaning and disinfection monitoring. I want to mention there's a recent article that was published this year from Donsky. I'll send a link to that as well, which did a study, an interesting study on automated dilution systems that were not dispensing really what facilities thought. So this study involved 10 hospitals in 4 healthcare systems across 5 states. And what they found was that there initially was 27% of facilities had inadequate concentration of their germicide to water in these dilution systems. 14% of them had no detectable disinfectant at all. And these were largely related really to human error. So it highlights the importance of ensuring that your housekeeping staff know how to use these automated dispensing systems, but also to implement some enhanced monitoring with all of those dispensers. And when they did that with one of these hospitals, they achieved correct concentrations in all of their dispensing units. So just some things to think about with your germicide systems. Just a word about bleach. So diluted bleach solutions, if you're mixing a 1 to 10 bleach solution, you need to be aware that that solution will expire in 24 hours. The chlorine dissipates, and after 24 hours, it's essentially just water. So those solutions should be discarded and replaced every day. You want to make sure you're labeling your containers with the date that it's mixed to ensure that it is effective. And then, sometimes this isn't practical, but wherever possible, use commercially prepared products, especially with bleach, because they're so unstable. A word about the quats. So quaternary ammonium compounds, they have a reduced effectiveness against Candida auris. Generally, unless they're enhanced, they tend not to be effective even at 10 minutes. And they also bind to copper fibers. So if your housekeeping is not using microfiber cloths, you are getting much less quat to your surface than you might think. Okay, I said I was going to talk a little bit about CHG bathing. So I'd like you to just consider implementing CHG bathing for the patient. Now, while the CDC is not currently providing recommendations for CHG use for patients who are colonized or infected with C. auris, CHG concentrations of 600 to 650 mics per mil are sufficient to kill Candida auris. So to put that in context, a 2% CHG solution provides 20,000 micrograms per mil. So remember, we need 6 to 650. So there's more than enough. So at the time that you apply that to the skin, it's sufficient to kill. There are questions, however, about persistence. If ideally what you want to use, particularly for a C. auris patient, is the no rinse product. And making sure that it gets massaged into the skin where it really can bind with skin proteins. It's also very important that your staff are using correct bathing techniques. And sometimes that can get really sloppy, but CHG really needs to get into the folds and the groins to be in folds and the into the groin and the armpits to ensure that it is touching the right places. Also making sure that you're contacting the webs between the fingers, the toes, the palms of the hand, and the fingertips. I have a really good CHG bathing tutorial that I'm going to include with the follow-up. And here I'm just sort of saying, when you decolonize the skin, you protect others. When you decolonize the nose, you protect me. So that's why we do nasal decolonization pre-surgical, because we want to prevent those surgical site infections. But here, what we're really trying to do is protect others. Just as an aside, I don't know that there's any effective nasal decolonization products for Candida auris at this point. So it's helpful to know and have your staff prepared for a single case response. When there is a single case of, Candida auris at your facility, a number of things are triggered. The first thing is that we're going to have a partner call within 24 hours of the case being identified. And that's typically with the clinical team, infection prevention, the local public health agent, and us here in the high priority MDRO team at OHA. So we'll discuss the clinical care, what's the background, what's this person's medical history, when were they placed on precautions, and then what are the next steps and recommendations. We'll talk about point prevalence testing being done as part of that partner call. And that for Candida auris would include collection of axilla groin composite swabs. I'm sorry, there's a typo, which would identify if transmission has occurred. You need to have eTour access for Arlen for the lab in order to be able to look up those results. So we'll have that conversation as well if you don't already have that access. And then the other thing that is triggered is an on-site responsive infection prevention ICAR, which is standard recommendation from the CDC as a result of a single case of CPO or Candida auris. I had hoped to have Sarah or Tracy come and talk, but they're not available, unfortunately. So here's the resources will be provided in the PDF. And then I would like to thank you for your time and attention. If you have any questions, I will sort of navigate through those now. And, if you have any interest, you want to have an infection proactive consult, I'm available to do that. And then my counterparts are Eppies, Heather and Evelyn are amazing. And we also, I have to mention, have an amazing antimicrobial stewardship pharmacist who has also created some amazing tools specifically for long-term care. So thank you again. I'm going to stop sharing. and then turn off the recording and see if there are any questions that folks would like to put out there.